Okay, so a 68-year-old male presents with palpitations, shortness of breath, and fatigue for the past 2 days. On examination, his pulse is irregular at 130 beats per minute, and his blood pressure is 140 by 90 millimeters of mercury. An ECG shows absence of P waves and irregular ventricular rate. Blood tests, including thyroid function tests, are normal. An echocardiogram reveals left atrial enlargement, but no significant valvular disease. Now, you can expect such kind of a question in an exam, and if you think about it, the answer to this is obviously atrial fibrillation. In this video, we'll go through all of these clinchers that can point towards atrial fibrillation, and we'll be talking about what is atrial fibrillation, the pathophysiology of atrial fibrillation. We'll be able to identify risk factors for it, classify it, identify its symptoms and signs, and then learn how to manage patients with atrial fibrillation. If you want to skip through any part, the timestamps are below and you can skip through it. So let's define atrial fibrillation. Atrial fibrillation is basically an arrhythmia that is characterized by rapid and irregular atrial contraction with the atrial beat per minute which is almost about 300 beats per minute or more. So you should know that this is the atrial rate and this is not the ventricular rate, because these both differ. Atrial fibrillation refers to the atria sort of quivering and shaking, and they can quiver so fast that the beats per minute can reach up to 300 or more. So what is the pathophysiology of atrial fibrillation? So there are many different reasons that we'll be talking about in this video, but for the majority part, the atria sort of form a sleeve around certain structures, as I've annotated in this diagram, which can be the pulmonary vein, the cavernous sinus, and the superior vena cava. So the atria sort of sleeve around it, and they can form ectopic foci. And from those ectopic foci, signals can come, such as normally there's the SR node, but then electrical signals can come from the ectopic foci, and that can lead to paroxysmal atrial fibrillation. This is basically what paroxysmal AF is, and don't worry about it, we'll study it more in detail later on in this video. So now talking about the risk factors, basically the causes that can lead to atrial fibrillation, these things are modifiable. And this consists of anything that can lead to raised atrial pressure, increased atrial muscle mass, atrial fibrosis, or inflammation and infiltration of the atrium. Anything leading to these things would, at the end of the day, sort of lead to atrial fibrillation. So we have got here the heart, and we've got here the lungs. So different diseases of the heart and the lungs can predispose one to atrial fibrillation. So the first thing is pericarditis. So judging from this, inflammation, okay, and probably raise our atrial pressure. Then there's hypertension, which can lead to atrial muscle mass, increased atrial muscle mass obviously, and raise atrial pressure. Coronary artery disease, heart failure, valvular heart disease, cardiomyopathy, congenital heart disease, previous cardiac surgery obviously can lead to atrial fibrosis, inflammation, and myocardial infarction. So all of these things, one way or the other, cause a certain pathology associated with any of these things, as mentioned above, such as raised atrial pressure, increased atrial muscle mass, atrial fibrosis, inflammation, infiltration of the atrium, etc. Now coming towards the lungs, so the first thing is COPD, then we have pulmonary embolism, we have OSA, we have pneumonia, we have pulmonary arterial hypertension, we have interstitial lung disease, ARDS, acute respiratory distress syndrome, lung cancer. So all of these pathologies can lead to the things mentioned above, and the pathologies in the lungs mostly lead to either raised atrial pressure or increased atrial muscle mass because of that pressure. Now, there are also some other things that are modifiable, and they are not necessarily linked directly or primarily to the lungs or the heart. So this can be hyperthyroidism, caffeine, they can be alcohol, rheumatic heart disease, or renal failure. If you didn't know, rheumatic heart disease used to be one of the most important causes for atrial fibrillation because of its involvement with the mitral valve. And now obviously other things are important because many countries seldom have a rheumatic heart disease now. Anyways, leading on to non-modifiable risk factors. As mentioned, these things or these factors are non-modifiable. You're just born with them and you just can't change them. So the first thing in this is gender. And as you can see from this hunk of a man, it's a man. So if you are a male, you're more prone to developing atrial fibrillation. Then there's an age, and this old retired guy is probably more prone to atrial fibrillation than a young guy because age plays a pivotal role in this. Many pathologies, as you saw, or many modifiable modifiable risk factors that we came across mostly do not happen in just one night. They happen over the course of a period of time, and thus age plays a big role. And you would never see a patient probably less than 50 years of age presenting with atrial fibrillation. There's always rare cases, but like for the majority part, they're mostly older than 55 years of age. Okay, another one is if you are white or Caucasian. And the last thing is genetics. I think genetics play a role in almost every single disease, but if you have a family history of atrial fibrillation, or if you have any condition that can lead to those risk factors because of genetics, such as, for example, if you have a very strong family history of acute coronary syndromes or any of those things, so you can be more prone to atrial fibrillation. Now, coming to the American Heart Association classification. It's not what you're about to see. Just don't panic and don't be scared, because this can be a bit intimidating, but I promise you, I'll make it very simple for you. Okay, so here it is. This used to be the AHA classification before. Now it's obviously changed, but many people still use this in practice, and thus I just, sort of thought about it that I'd share this thing with you in case you work in a hospital and someone mentions these things, so that you're just not confused about it. Because you know what, people take time to adapt and change, and that's the reason. Okay, so there are mainly 5 classifications. First thing is paroxysmal, then the persistent, then long-standing persistent, then permanent, and non-valvular. Okay, so paroxysmal is that kind of a AFib which, for example, lasts to like 2 days or maybe 1 week, not more than 1 week, and it does revert back to sinus rhythm without any intervention. So you do nothing for the patient, and the patient gets back to sinus rhythm within 7 days. This is for you paroxysmal AF. Okay, so that was the thing I was talking about. If the person has sort of the atria, a form of sleeve around the cavernous sinus, or for example the superior vena cava, maybe the inferior vena cava, or the pulmonary veins, and the ectopic foci from there, they just shoot signals, and the person just sort of develops paroxysmal AF, and then it just resolves spontaneously without any intervention. So that was paroxysmal AF. So persistent AF is something that does last more than 7 days, and this does revert back to sinus rhythm, but you have to do something about it. And what do we do about it? We'll just later on in this video discuss, but like you have to do something for it, and only then does it revert back. Long-standing persistent, it's more than 1 year. It takes almost 1 year, and the patient does revert back to sinus rhythm, but with aggressive intervention. You have to do loads and loads of things, and then the patient does revert back to sinus rhythm. Permanent is that it is more than 12 months, and you've tried repeatedly, and the doctor and the patient just come to a consensus, and they're like, you know what, this isn't working, and let's just shift back to rate control and stroke prevention, because that's more important now. Then there's non-valvular, and this basically, as you know, this is self-explanatory, because the atrial fibrillation is basically not caused by valve disease. And then this rhythm control is the first thing that you do, second is rate control, and the third one is the stroke control. So now this was the old one. This isn't the new one. The new one is like fairly simple, but here it is. So it's basically divided now into 4 stages. So the first one is you are at risk of atrial fibrillation. So this basically refers to modifiable and non-modifiable risk factors. Stage 2 has pre-atrial fibrillation, which means the patient does have evidence of structural and electrical findings that predispose the patient to atrial fibrillation, but he's just not there yet. But he will be there yet if there's nothing, if the doctor does nothing about it, or the patient does nothing about it, he doesn't reach out, something's gonna happen. And that something is atrial fibrillation. Stage 3, the person has atrial fibrillation. And this is the same thing we talked about: paroxysmal, persistent AF, and long-standing. Paroxysmal was 1 week, it resolves spontaneously. Persistent AF was 12 months, and then it's resolves. And then long-standing persistent AF is that it just, it's permanent, obviously. And then there's successful ablation, which we'll talk about later in this video. And stage 4 is obviously permanent atrial fibrillation and no further attempt at rhythm correction. Okay, so the symptoms, we'll be talking about the symptoms now. Classification for this is basically asymptomatic atrial fibrillation. Then either you have non-life-threatening symptoms, or you have life-threatening symptoms, and you have probably develop complications from it. And then you have hemodynamic instability. So believe it or not, 35% of patients who have atrial fibrillation are basically asymptomatic, and it's an incidental finding. This patient comes to you, and maybe he collapses, or like he's just feeling palpitations, he's just feeling a bit weird, because those are the basic symptoms, and patient feels very fatigued. So now atrial fibrillation with non-life-threatening symptoms. These can be palpitations, fatigue, shortness of breath, dizziness, anxiety, and chest discomfort. So basically, these symptoms are non-specific. None of these symptoms directly point towards atrial fibrillation, because the signs are more important than the symptoms in atrial fibrillation. Okay, so atrial fibrillation with life-threatening symptoms. So like everything that was non-life-threatening, but like severe. So there's like severe chest pain. There was shortness of breath in non-life-threatening symptoms, but in life-threatening symptoms, the shortness of breath is severe. You don't feel dizzy or fatigued, you just sort of pass out, right? Then you may have stroke symptoms, you have a rapid heart rate, tachycardic, and you have hypotension. So the easier way to remember is this, like everything that a non-life-threatening patient has, and just life-threatening is severe form of that symptom. Then the patient can present with hemodynamic instability, which basically sort of points towards hypotension, syncope, and rapid heart rate. Okay, these were the symptoms. Now the signs are, in my opinion, far more important than the symptoms. In signs, the first and foremost is irregular heart rate, or the pulse, as you can say. So when you take the pulse of the patient has an irregular pulse. It doesn't sort of form a pattern whatsoever. It's chaotic. It's everywhere. The second is obviously variable heart rate. Sometimes it's 160, then it just comes down to 120, then it goes to 130. It just sort of doesn't fall into place. And because of that, since the atria are sort of just quivering and they just don't know what to do, the blood pressure is variable. If you just check the blood pressure 2 minutes after you checked it, it's going to be different. Half an hour is different. 10 minutes is different. Every single time you check it, it's just completely different. So he has a variable, or she has a variable blood pressure. Then the patient can have heart failure symptoms. And a very interesting point to note is that there is an apical radial pulse deficit. Now, what does this mean? So imagine that you suspect a patient that he has atrial fibrillation. So what do? You sort of place the diaphragm of the stethoscope on his heart, and then you sort of palpate his pulse. And both of these do not occur in synchrony. So maybe you hear the heartbeat first and the pulse later, or maybe the pulse first and the heartbeat later. It doesn't sort of beat in synchrony with each other, which obviously it shouldn't be like this. They always should be in synchrony. The investigations, ECG is obviously very, very important. There are certain things on the ECG which point towards atrial fibrillation. And the first thing that we even went through in our scenario were absent P waves. So if a person has an ECG and there are no P waves, rest assured, most probably, there can be different causes, but most probably it is atrial fibrillation. If a person has irregular RR intervals, if you check the ECG, in every lead there is an irregular RR interval, it can be atrial fibrillation. And then there are fibrillatory waves. So like in between the ECG and in the different leads, there's a flat line with fibrillatory waves. So these all point towards atrial fibrillation. ECGs are very important, and so are the signs. Okay, then there can be echocardiography. If you do an echocardiography and there is some structural heart disease, it can point towards atrial fibrillation. Chest X-ray can point towards any pulmonary cause or anything that may be related with the heart. You can do blood tests, and blood tests can be of different types. Obviously, you can do a full blood count. You can do urea and electrolytes. You can do liver function tests, thyroid function tests, because we did mention that, hyperthyroidism can lead to atrial fibrillation. Calcium and magnesium, very important. Blood glucose, very, very important. So all of these things sort of, are important because you might find a cause in it that would link the abnormal finding with atrial fibrillation. So how do you manage a patient with atrial fibrillation? You know everything about it. Now let's see how to manage it. So I have classified this very basically. So first of all, the first goal should be to treat the underlying cause, because if you treat the underlying cause, the atrial fibrillation is gone. The second thing is the heart rate. So if you cannot treat the underlying cause, you can definitely control the rate. And then if you can't control the rate, you control the rhythm. And then if you can't control any of these three, you just save the patient from future mishaps, which is obviously the biggest one, stroke. So underlying cause, as we had talked about, everything related to the heart. You can see in this diagram here, different diseases, and obviously the lungs as well. We all talked about hyperthyroidism, caffeine, alcohol, rheumatic heart disease, and renal failure. Now talking about the rate. So the symptoms that you experience during atrial fibrillation are mostly to do with your increased heart rate. The patient is tachycardic, and he associates those symptoms because of that, or develops because of that. So a patient still continue to have atrial fibrillation, and the patient, the main goal in this is to not do anything with the rhythm, because the patient will have atrial fibrillation regardless. And what you do is you just try to control the rate. So when you decrease the heart rate, the severity of the symptoms sort of decrease. So you put them on beta blockers, that's or any beta-1 selective antagonist, because studying basic physiology, the heart has beta-1 receptors, and those are responsible for heart contraction. So if you block them, the heart contraction decreases, or the heart rate decreases, and thus you have a decreased heart rate. So you can put them on beta blockers such as bisoprolol, or you can put them on non-dihydropyridine, a calcium channel blocker such as verapamil or diltiazem, and digoxin can also be used. Now, you must note that rate control is suitable for patients who have persistent atrial fibrillation, or as well as old-aged patients in whom rhythm restoration is unlikely. So you have sort of tried over and over again over the course of time, at the time the patient was diagnosed with atrial fibrillation, and you just sort of, the patient just doesn't revert back to sinus rhythm, he just always goes back to AF. So in those patients, rate control is the primary goal then. Now coming back to rhythm, a DC cardioversion is used for paroxysmal AFib. So if a patient presents to you and the onset was less than 48 hours, the best thing to do is to go for DC cardioversion, but obviously after transesophageal echocardiography. Why do this? Because there could be a clot in the heart. You never know that, and you never want that. So it's very important to do a transesophageal echocardiography or TOE. And you can also do a DC cardioversion if a patient is hemodynamically unstable. So regardless of whatever AFib it is, if he's hemodynamically unstable, the best thing to do would be to obviously cardiovert him, use DC cardioversion. You can also put patient on amiodarone or flecainide, and this is known as pharmacological cardioversion. And flecainide is not used if a patient has structural heart disease such as atrial enlargement or anything of that sort. Now, a patient should be anticoagulated with direct oral anticoagulant 3 weeks before DC cardioversion, and this should be continued 4 weeks post cardioversion. So if someone was, for example, you just decide, this patient has to be cardioverted, so you give him rivaroxaban for 3 weeks before DC cardioversion, and then you continue it 4 weeks post cardioversion. So rhythm control is sort of based on several factors such as severity of symptoms, how severe the symptoms are, the likelihood of successful rhythm restoration. The earlier you cardiovert the patient, the better the results, and the lesser the age, and the better the results. And presence of comorbs, and if a patient is a candidate for AF ablation. Okay, let's move on to ablation. So this was basically paroxysmal AF. So if you just sort of find the cause for atrial fibrillation, and you find out the cause is basically the sleeve that extends into any of these structures, you just go there and you just ablate it. So when you ablate any of these places, what happens is that those ectopic foci, they no longer exist, and the patient relatively stays in sinus rhythm longer if you successfully obviously ablate. Okay, now coming back to stroke. So we use a CHA2VAS2C score for stroke. This is used to assess if a patient should be put on a direct oral anticoagulant. So this is basically the scoring system. If a person has congestive heart failure, you give him 1 point. Hypertension, 1 point. Age more than 75, 2 points. Diabetes mellitus, 1 point. If he has a previous stroke or transient ischemic attack, 2 points. If he has vascular disease, 1 point. If his age is above or 65 but less than 75, 1 point. If she is a female, obviously, 1 point. Okay, so when do you start a direct oral anticoagulant? In males, if score is 1 or more, and in females, if score is 2 or more. So the benefit of a DOAC it is prescribed is because you really don't need to monitor patients' INR with it. So it's a relatively safe drug. And examples include apixaban, dabigatran, edoxaban, and then rivaroxaban. And obviously, if it is contraindicated for whatever reason, warfarin is second line. This was all about atrial fibrillation. If you found this video helpful and it sort of cleared any of your doubts, be sure to subscribe for future videos. Maybe like it and leave a comment. If you sort of have any questions about it, I'll be more than happy to answer. And until the next video, goodbye.